Decubitus chest would be 4 views for us at our clinical site. We do a PA and lateral chest. If the patient can't stand, you'll do AP in the stretcher and a lateral. We do both Decubitus views, a right and a left. Those can be done either AP or PA, depending on patient ability. These are done looking for pleural effusion, and if you remember, that's fluid in the pleural space. You're going to focus on side down, so it's side down of interest because fluid drops, air rises. It can be done in the stretcher or with the patient on the table. Remember, Decubitus means lying down. This projection, the patient's going to be lying on one of their sides, and you're going to have that horizontal beam. Now remember, those Decubitus views always have that horizontal or parallel beam to the floor. We're looking for air fluid levels, right? We want to demonstrate the fluid in the pleural cavity, which is pleural effusion. And then they're helpful in determining if the effusion is free-flowing. If there's enough fluid, that'll be sampled by a procedure called thoracentesis. And then it's potentially looking for small amounts of air in the pleural cavity. If you remember, that's pneumothorax. Right. What is pleural effusion? We just went over that again. But there's multiple medical conditions that can cause it. Some most often are congestive heart failure, pneumonia, liver disease, and pulmonary embolism. We do these views most often on post-operative cardiac patients. Thoracentesis is a procedure in which a needle is inserted into the pleural space between the lung and the chest wall. It's done to remove excess fluid, known as pleural effusion, and to help the patient breathe easier. It may be done to determine the cause of your pleural effusion. They might take testing to send to the lab to see what's going on. And then we often do a chest x-ray after that to look for pneumothorax, just in case that needle caused a pneumothorax. But the PA and lateral may show the pleural effusion or it may not. So your PA and lateral chest may look normal. This one is a fairly severe example. Obviously, a good amount of this lung is not visualized, right, because it's white. And remember, fluid is white on the x-ray. This lung clearly goes all the way down to a claustrophrenic angle. It has the triangle. Any rounded appearance here is usually fluid. And you can see on the lateral the difference between the two claustrophrenic angles. Here is the left side coming down to a point. The right side is rounded, and there's a clear space in between the two, so they're not expanding at symmetrical. You're going to do both left and right decubitus views. The patient's going to lay on their side. You're going to place a sponge underneath them. Why? Because your side of interest is the side down. So you don't want their chest directly on the table, because then you're going to clip with the cassette. So you raise them up. I use the blue rectangle sponge that we use for stretcher chests. I put that underneath my patient. Adjust their hips and shoulders, making them lateral. You want to raise the arms up and out of the way, have the patient raise their chin. Make sure you have light on the sponge here, down here, because the chest will kind of dip into it a little bit. You're going to choose either crosswise or lengthwise, exactly the same way as if you would position them for a PA chest against the wall stand. You're going to have to prop the cassette up behind the patient, either with tape or a sandbag to hold in place. The cassette position, ideally you are still centering in the same area, T7 with a triangle of light over the shoulders. The fluid will appear white, and you can see there's a clear air fluid level. There's linear lines here coming across the chest. Everything down here that's white now is the fluid. Fluid drops, air rises. Okay, there may be breast tissue in the way that you may need to adjust or help the patient move out of the way if they're very large breasted. Here's another sort of severe example. This lung field is completely white. This is showing you a good amount of fluid too. Here it's really rounded. This is all white with fluid down bottom because the fluid drops. This is a demonstration this patient was upright, and this is what their lung field looked like. Again, rounded or blunted. You can't see the angle of the claustrophrenic angle like you can on this side. They laid the patient down. You can see how much fluid is in that lung. on a decubitus. Just another example, upright versus decubitus. Look at the good amount of fluid on here. It's a better demonstration. Oblique chest. I have never done an oblique chest as a technologist, but it's in your textbook, and so I would like to just go over it. You won't see it routinely. It may be something that's requested at an offsite or randomly by a doctor. Most oblique projections have been taken over with CT. A CT of the chest is a more in-depth procedure than an oblique chest. But, so, the textbook identifies some of the areas that you would look at for oblique chest. So you could identify or separate a pulmonary or mediastinal mass or opacity. They might be looking at a PA chest and see something that's a questionable mass. If you oblique the patient, it might just show them a different view. They might be for studying lesions that are visible on the PA but not on the lateral. Determine a site or origin of an intrathoracic lesion. It sometimes is an aid in the differential diagnosis of cardiac or great vessel enlargement. So you're going to do 2 obliques. So you're going to usually a PA and lateral chest and then the 2 obliques. They could be done PA or AP. You're going to rotate the patient 45 degrees and you want to include all the lung fields. So you can see here, one oblique elongates one side of the chest and foreshortens the other. And then you'll go the opposite. You're going to elongate one side of the chest and foreshorten the other. Here's just a cheater that we will go over more in depth with rib views, and you will learn to love it. But so anterior obliques, with where the patient is standing PA, the part away is elongated. So RAO, where the right anterior side of the patient is touching the image receptor, the left side is away from the image receptor, it is elongated. LAO, left anterior touching the image receptor, right lung is pulled away, right lung is elongated. And it's reversed when the patient's in a posterior oblique where you're shooting AP. AP, I say at part. RPO, you're looking at the right. LPO, looking at the left. So posterior obliques, you're looking at same side. PA, anterior obliques, you're looking at the part away. Elongates that part of the chest. You may also get an order for a chest x-ray with something called nipple markers. The patient most likely has had a chest x-ray. There's a potential nodule, or they're questioning if this area is actually a nipple shadow or something calcified near the nipple, and they will send the patient back in for a repeat chest x-ray with nipple markers. There are these little adhesive stickers with a small BB on the end, and you will ask the patient to put them on their nipple, not on the hospital gown because it'll move, but directly on their skin, and you'll do the chest x-ray with those, and you'll annotate the image, and I just write with BB on my image. But you can see the small little BB here is identified because they were looking at this nodule. So they were trying to determine if this was actually the patient's nipple or not. And as you can see with the nipple markers up here, it is not, and the mass is still here. So that's what those are. And that